calmed down out there in California, Gretchen? Are you still having fires?
Always fire season, and
Good afternoon or good morning, depending on the time zone you're in. Thank you for joining BPC for the release of policy recommendations to improve the availability of long-term services and support. I'm Bill Hoagland, and I have the pleasure of working with our health team here at BPC on the challenges that face the delivery of quality healthcare for all Americans. I think some of you know that BPC has had a long history of working on long-term care. This work builds on work from a task force a few years ago, led by former Senate Majority Leaders Tom Daschle and Dr. Bill Frist, former governor, and HHS Secretary Tommy Thompson, and the late Dr. Alice Rivlin. Congress is currently considering options right now to expand the availability of Medicaid to home and community-based services as part of the president's Build Back America agenda. As I think we all know, the politics of that reconciliation bill the majority party is considering is a challenge. Indeed, the House Ways and Means Committee yesterday's draft revenue plan includes one element of this issue that we're going to talk about today, and that includes a tax credit for caregiving expenses. And there could be an expansion of Medicaid home and community-based services in the final package. The critical to the successful expansion of those Medicaid services will be the support provided to states in terms of flexibility, technical assistance, and resources. Even with an expansion of Medicaid services, there are other steps that policymakers could take to address the needs of individuals and families who need long-term services and support. These include such things as a better integration of care for those who are eligible for both Medicare and Medicaid, the population, of course, known as the dual eligible individuals. We could also have better and more affordable options to buy into Medicaid for workers with disabilities. We could have private sector options for to help them make private long-term care insurance more viable for those who can afford those premiums. There are ways to help offset costs for the caregivers who incur costs on behalf of their family members, such as what I mentioned here earlier, being considered today in the expanded tax credits for caregiving expenses on the Hill. And there are new options to help provide services for those who do not qualify for Medicaid, some of which we will be discussing here today with an expert panel and individuals. Finally, just let me say, on behalf of BPC, I extend our sincere thanks to the SCAN Foundation and the Robert Wood Johnson Foundation for their support of today's report and this event. Before I turn this over to Kathy Hempstead with the Robert Wood Johnson Foundation for her opening remarks, I want you to know that Catherine Hayes, our Director of Health Policy, and so instrumental to our work in this area over the last many years, cannot join us today because literally she is living this issue in real time with her elderly parent as we speak. So Kathy, I'm turning it over to you.
Sure that many of you have as well. I think the need for long-term care is something that we can all relate to, and it's maybe the aspect of healthcare where unmet demand might be the greatest. One of the statistics in the BPC report that accompanies this event today was that 14 million adults reported a need for long-term care services in 2018. And while that's about half the estimated number of adults without insurance, in some ways it's really a much sort of greater magnitude of need because all of those adults are reporting a need for services and often really very extensive services. And that's a number that's only going to grow as our population ages. This is such a complex field, and I think Phil alluded to a lot of it. There's a lot of sort of disparate aspects of demand with the elderly, the disabled, and people living with chronic illnesses. And there's also a wide range of services needed, and a very disparate kind of supply with a lot of family caregivers and also a poorly paid and under in short supply paid workforce. And since it's such a complex problem, there are a lot of potential solutions. And today we're going to talk about a lot of different policy ideas, some of which are under active consideration, like expanding federal funding for home and community-based services, better supporting family caregivers, and then some other ideas that, may be something that will be considered in the short term, like finding ways to allow people who don't qualify for Medicaid to buy into getting access to home and community-based services. And that's something that we're very interested in, and we've supported some work on that we're going to hear about today. And even there's some discussion in the report about ways to reform the long-term care insurance industry, which, right now is not a particularly helpful part of the solution, and is not a good book of business for the carriers, and is also serving a small population that has a lot of difficulty affording the product. But I think there's, some things that might get discussed about that today as well. Over the weekend, I happened to read an op-ed in the New York Times that some of you might have read by Addie Barkin, who is a really well-known patient advocate and advocate for coverage. He lives with ALS, and he's a really eloquent spokesperson for some of the needs. And I just wanted to share a quote from the article that I thought was a really nice statement. He said that the pandemic has shown the urgent need to transform America's social contracts. We're the richest nation in the history of the world. We have money for endless wars, space force, and tax cuts for billionaires. But when it comes to ensuring everyone has basic health care, we can't seem to scrape together the money. And I think, that's a really impactful comment. There's a lot to it, but I feel like there is maybe more opportunity and energy around this space than there has been in a long time. So, I'm excited to see what happens, and really think this conversation today is very timely. And BPC has a long history of addressing the many facets of this issue in a thoughtful, pragmatic, and of course, bipartisan way. So today's discussion and the accompanying report and the presentation is just another and an important string of contributions to this area that we at Robert Wood Johnson Foundation are very proud to support. And with that, I'll flip it over to Gretchen.
Wonderful. Thank you so much, Kathy. We at the SCAN Foundation are just honored to be involved in this work with you and the team at the Robert Wood Johnson Foundation. And most importantly, are really grateful to be here for this important conversation today. My name is Gretchen Alkema. I serve as Vice President of Policy and Communications for the SCAN Foundation. We envision a society where older adults can access the full range of health and social care needs and services that are of their choosing, that really meet their needs on a daily basis. And as we've already heard, as all of us grow older, most people encounter daily living challenges, like getting help with these ongoing needs that can be involved from going to the grocery store to getting assistance with personal care needs. Things like, how do we manage chronic and serious illness on a daily basis, while also worrying about how to pay for care or how to find services, and wondering how we're going to be able to live in the place that we call home. We've had supported many different polls over the years, and that thing consistently rings true, that people want to live well in the place that they call home, even if that changes in lots of ways. So looking at how to get services and supports in that place of their choosing, the pandemic only amplified that in extraordinary ways. And right now, there really isn't a coordinated or easily navigated system of care for people to get the kind of support that they need in a way that helps them live in the most independent way possible. So the time for solutions really is now. And we at the SCAN Foundation support effort that focuses on both federal and state level financing policies that create meaningful care choices to older adults and help support family caregivers, both of today and of tomorrow. And that looks like things like incentivizing coordinated and quality care inside of Medicare, helping to shape Medicaid reforms that are responsive to local realities, and encouraging new long-term care coverage solutions that address America's future needs. We're so thankful for this, the Bipartisan Policy Center, for today's conversation and the accompanying report that outlines several new proposals that expand the availability of home and community-based services for low and middle income individuals, while also outlining a number of important private sector options from previous work that was done for those who have more resources to spare. We honor the efforts of the Bipartisan Policy Center staff and several experts who made this report possible. Looking forward to a great conversation today. But I'd really like to thank a number of BPC staff and experts who put together an excellent body of work. Catherine Hayes, Lisa Harudian, Brian O'Gara, Eleni Salyers, Kevin Wu, Henry Claypool, Bill Hoagland, Allison Reiser, Ann Tomlinson, and Elizabeth Burke. And so now, without any further ado, to kick this thing off, I'm going to turn it over to Lisa, whose name I probably butchered. I'm so sorry. But just so glad that you're here, and thanks for getting this started. Lisa.
Great. Thank you so much. Hello, everyone. I'm Lisa Harudian. I'm an Associate Director for the Health Program at the Bipartisan Policy Center. Thank you all for joining us. Today, I will provide an overview of the recommendations that appear in the Bipartisan Policy Center's new report, Bipartisan Solutions to Improve the Availability of Long-Term Care. This report focuses on federal policy solutions to improve the availability of long-term care for individuals of all income levels through both public and private sector reforms. Specifically, BPC's recommendations aim to achieve 5 main goals. First, to expand access to home and community-based services. Second, to address disparities in the delivery of home and community-based services. Third, to provide support for family caregivers. Fourth, to improve the viability of the private long-term care insurance market. And fifth, to promote public education on long-term care. I'm going to highlight just a few key recommendations today. And if you're interested in learning more about any of these recommendations, we would love for you to check out the full report, which is now available on the BPC website. So regarding our first goal, to expand access to home and community-based services, BPC recommends that Congress make HCBS available to individuals with long-term care needs who are not eligible for Medicaid. So we're essentially targeting Medicare beneficiaries who meet certain functional eligibility requirements, and we hope to provide some HCBS to meet those needs through a buy-in model. Under this approach, services would be available through fully integrated care models, including fully integrated dual eligible special needs plans, PACE, or other models approved by the Secretary of HHS. And this would include sliding scale subsidies to help individuals with low to moderate incomes access those services. BPC contracted with ATI Advisory to estimate the federal costs of this proposal. So you'll hear more details about this proposal and the ATI's modeling very shortly. But before we turn to ATI, I will quickly touch on a few other recommendations in the report. Now, because it will take some time and planning to implement the buy-in approach, BPC recommends that Congress develop a transitional program to support the expansion and development of integrated delivery models where they are currently unavailable, and to build caregiver capacity until the new HCBS program is fully implemented. And regarding our second goal, to address disparities in the delivery of HCBS, BPC recommends that the Secretary of HHS collect data and issue an annual report on disparities in access to home and community-based services and make recommendations to Congress to address those inequities. Regarding our third goal, to provide support to family caregivers, BPC recommends that Congress establish a refundable tax credit for caregivers to help with those out-of-pocket costs for paid long-term services and support related care. Next, regarding our fourth goal, to improve the viability of private long-term care insurance, BPC recommends several reforms, including a standardized and simplified retirement long-term care insurance product and accommodations to support conversion products that transition from life insurance to long-term care. Regarding our fifth and final goal, to promote public education on long-term care, BPC recommends incorporating long-term care planning into retirement education topics to encourage planning and address common misconceptions about coverage. So in summary, no single solution will address the needs of those who require long-term services and supports, but we hope these recommendations advance discussions among policymakers on some bipartisan solutions to improve access for children, adults, and seniors with functional and cognitive impairments. So I will now turn it over to Allison Reiser with ATI Advisory to talk more about their modeling for the buy-in recommendation.
Thank you, Lisa, and thank you to everyone who's joining us today. My name is Allison Reiser. I'm with ATI Advisory, and ATI recently had the opportunity to partner with the Bipartisan Policy Center to model out the potential costs of providing some level of home and community-based services to Medicare beneficiaries in need as one part of their broader report. You could pull up the slides and advance to the first slide, please. Next slide. Thank you. So as you've heard from Gretchen and Bill and Kathy and Lisa, there's a considerable portion of the Medicare population who have long-term services and supports needs, but they really have no systematic way to access those services currently. And this unmet need can lead to significant longer-term medical decline, as well as costs to both the Medicare and Medicaid programs. And really, additionally, even when an individual is able to purchase these services in the private market, the services typically exist in a silo, and so they're not coordinated in any way with that person's Medicare benefit or their physical health and acute care benefits. So with that as background, again, ATI and BPC partnered to estimate the cost of providing some amount of home and community-based services integrated with acute medical care to Medicare beneficiaries in need. A few important things to note: this project was really the first step. So we did not develop policy specifications such as program eligibility or program administration. Really what we did was estimate the cost ranges for providing LTSS to determine the merits of that further policy design. And then one other item that's important to note here: this is not an insurance product. What we did here was price out the cost of allowing individuals to access these services as they need them. So similar conceptually to what you see in the Medicare Advantage special needs plans, where an individual can enroll upon clinical or functional eligibility. Next slide. So the cost model really included two broader elements, each with a lot of layers underneath. First, we sized the population of Medicare beneficiaries living in the community and likely to need some level of long-term services and supports. Only beneficiaries who don't already have full Medicaid coverage were included, because we are assuming that full dual beneficiaries do have access to these services through their Medicaid benefit. And we did this based on the number of beneficiaries who need help with activities of daily living and instrumental activities of daily living. So we created a composite formula essentially that looked at the number of ADLs and IADLs that an individual needs assistance with. And we also looked at markers and diagnoses such as cognitive impairment and Alzheimer's disease and dementia and intellectual or developmental disability. And then we grouped beneficiaries based on their income level to inform potential subsidy cutoffs. One note here is that due to data methods and accessibility that were defined at the outset of the project, the numbers that you're going to see today, this initial population sizing was limited to Medicare beneficiaries aged 65 and older. However, the policy design ultimately would consider all Medicare beneficiaries regardless of age. And then if you look at the right-hand side, the second component was we estimated, or the lower-hand side, sorry, we estimated costs associated with these benefits themselves. And we layered in a cost savings assumption based on two broader attributes. So the first aspect was purchasing power and pooling of risk, and the ability for CMS or states or health plans to negotiate a lower out-of-pocket cost than presumably an individual would be able to negotiate on their own behalf. And then second, we estimated acute care savings that would likely occur as a result of integration and addressing unmet long-term services and supports needs. So the potential impact on decreased hospital utilization and emergency department visits, for example. I'll say our savings estimates were conservative, and they only considered the short-term savings to Medicare, and that in reality, this sort of benefit would likely have a greater volume of program savings and ultimately would likely impact both Medicare and Medicaid. Next slide. So because this project did not involve the development of policy specifications, what we did was model out three different cost and coverage assumptions. These resulted in really the full range of what we thought were the potential costs based on how generous the LTSS benefit ultimately could be. Because recall, this is not an insurance product. So on the left-hand side here, the first scenario that we modeled out was a limited dollar amount benefit, and we priced this at $450 per person per month. We assumed beneficiaries would use the entirety of this benefit each month, and we identified this price point as our lowest cost anchor. And this was based on other policy and programs that exist. For example, Congress for several years now has introduced legislation to test a limited LTSS benefit in the Medicare program, what they've called the Community-Based Independence for Seniors Act, or the CBI SNP legislation, and their dollar amount was in the $400 to $450 per person per month range as well. And they had the assumption of that program being budget neutral after several years. We did not define services for this first scenario, only the dollar amount, which is similar to the approach that was taken by Congress. In the middle here is the second scenario, and this would be a benefit that would focus exclusively on providing personal care services to beneficiaries in need. We assumed a weekly average of 10 hours of personal care, and this was based on industry experiences and research, and it ended up being about $900 per person per month. And then we priced into this a discount on what we assumed the cost of services would be in the private market compared to, again, the impact of purchasing power and risk pooling. And then the third scenario on the right is our highest cost anchor. So we looked at state 1915C HCBS waiver spend per person, and we modeled out those costs using the median per person state spend as well as the 90th percentile state spend. And the intent with this scenario was not to assume that the program would be administered through a 1915C waiver. It was not to assume that the specific benefits in 1915C waivers would be the same benefits in this program, but really our approach here was assuming that Medicaid recipients, typically are receiving full LTSS needs being covered in a 1915C waiver in many instances. And so we were assuming that same sort of cost if Medicare individuals were to receive coverage for their full LTSS needs. Next slide. So these data are all available in that accompanying report. So I'm not going to read through everything here, but I will call out a few numbers. Depending on subsidy assumptions, that is at what level CMS or Congress would provide a full premium subsidy, and also whether a partial premium subsidy existed and at what income level. We estimated that the annual net federal costs for providing subsidized coverage would range from between $1.1 billion and up to $12.7 billion. And it would subsidize approximately 675,000 beneficiaries. Of note, the total number of beneficiaries that we identified as having long-term services and supports needs in the community and not already eligible for Medicaid is approximately 3 million at any given point in time, based on the criteria that we set for needing long-term services and supports. And of that 3 million, about 1.2 million are what we would consider lower and moderate income. So if you think about that 675,000 subsidized beneficiaries, it reflects a little bit more than half of the population with an LTSS level of need at that low to moderate income level. And again, this effort was not about designing policy specifications. I'm going to turn to that here. If you could go to the last slide, you'll see some detail on this in the report. Really, future research and conversation, I think, will need to tackle some of these policy details, including where is the program administered? Is it a state program, a CMS program? What the eligibility criteria are from a functional impairment level, for example, what the benefit design is, how the savings might be reinvested into the Medicare Trust Fund or used to lower the premium cost for unsubsidized individuals, and really how to think about integration as an individual moves in and out of Medicaid status over time, because this is not a replacement of Medicaid. It would be a complement to individuals who are fully duly eligible currently. And so with that, I will turn it to Marilyn Serafini with the Bipartisan Policy Center.
Great, thank you so much, Allison. So at this point, we are going to move to a panel discussion. We have 4 incredible panelists with us. But before I tell you who they are, I'm going to let you know that if you have questions for our panelists, please submit them. It doesn't matter whether you're, live chat on YouTube or Facebook or on Twitter. You can get us questions through any of those platforms using the hashtag BPC Live. So again, that's hashtag BPC Live. And you can start sending in your questions as soon as you are ready. As I mentioned, we have 4 panelists who each bring a unique perspective. Lena Sharma is a project manager and senior policy analyst at Community Catalyst. Henry Claypool is policy director of Community Living Policy Center at the University of California, San Francisco. And I also have to note that Henry is a consultant, a very valued consultant for the BPC. Amy Tuarson is executive director of the National Academy for State Health Policy. And Caroline Pearson is senior vice president at NORC at the University of Chicago. So we're going to start off our conversation with Lena, who is going to provide us with an overview of Medicaid long-term services and supports. And she's also going to give us an overview of work on dual eligible individuals, those who qualify for both Medicare and Medicaid, not just qualify, those who have both Medicare and Medicaid. After Lena, we're going to turn to Henry, who's going to give us a review of the changes in the American Rescue Plan. And he's also going to tell us what we know about long-term care provisions in the upcoming budget reconciliation. After that, we're going to hear from Haming, who is going to give us an overview of what states are doing in light of increased funding under the American Rescue Plan and other state efforts in the area of long-term care, including caregiving. Finally, we'll have Caroline Pearson. She's going to discuss research on the forgettable middle and how solutions can be targeted to prevent spending down to Medicaid. So for right now, I will turn it over to Lena.
Thank you, Marilyn. Good afternoon, everyone. And thanks to the Bipartisan Policy Center for hosting this great event and inviting Community Catalyst. My name is Lena Sharma from Community Catalyst's Center for Consumer Engagement in Health Innovation. And just for those who may not know, Community Catalyst is a leading nonprofit national health advocacy organization. We're dedicated to advancing a movement for health equity and justice. Our mission is to really build the power of people to create a health system that's rooted in race equity and health justice, and a society where health is a right for all. At the Center for Consumer Engagement and Health Innovation at Community Catalyst, we really work to build community engagement in innovative models of healthcare. We focus on vulnerable and historically underserved populations. The area in which I focus on and specialize in is the dually eligible population. Those individuals who are on both Medicare and Medicaid. There are currently 12 million Americans who are on both Medicare and Medicaid. These individuals have complex medical and social needs, have frequent interactions with the healthcare system, making these two programs especially vital to their healthcare security. These individuals are disproportionately from communities of color and experience systemic racism and ableism within the healthcare system. So on paper, it seems pretty straightforward, right? Medicare covers prescription drugs, physician and hospital services, skilled services, either at home or in a rehabilitation facility after an acute event. Medicaid provides wraparound services that Medicare doesn't, such as covering premiums or cost sharing. And Medicaid is the primary payer for long-term care, both institutional care as well as home and community-based services. However, in reality, as many of us know, navigating these two public health programs results in fragmented, uncoordinated care, results in a poor care experience for the individual, and misaligned incentives across these two programs result in higher costs. So our work at Community Catalyst and at the center focuses on policies and practices that will improve how these two programs work together so that the individual receives the best care possible based on what their health care and what their life goals are. Our work really focuses on, and our policy priorities in this space focus on ensuring there is a robust community voice represented in the design, implementation, and oversight of models of care that impact this population. Policies really that are developed and implemented are taking into account social determinants of health. You know, just a note, and many of you probably know this already, but over a third of dually eligible individuals rely on home and community-based services to stay in their homes. And in addition to these healthcare related needs, these individuals are exposed to additional social risk factors. You know, there's housing insecurity, food insecurity, transportation issues, loneliness, and social isolation. And as we all know, these last two are even more pronounced during this pandemic. We want to ensure that dually eligible individuals are presented with options for their care in a manner that is comprehensive, inclusive, and meet their needs, so that if they choose to enroll in a program such as an integrated care program, it is a person-centered process. And when we talk about the long-term care system, we look to a system that is person-centered, that is equitable, that advances racial justice, and is sustainable. And so those are some of the top line priorities that we focus on. And I am sure that in our panel discussion, we'll get into many of these points with the panelists. But I'll now turn it over to Henry Claypool. Thank you.
Thank you, Lena. Thanks for having me today, and it's my privilege to kind of give you a brief overview of the America Rescue Plan and maybe get into a little bit of the detail about the reconciliation package. Again, all of this relates to Medicaid HCBS. So the American Rescue Plan was really passed, as we all know, in response to the public health emergency around COVID. So there was a real need for relief in this area of Medicaid HCBS. It's often not appreciated that this was not addressed in the CARES Act, this part of the delivery system, Medicaid HCBS. So it really stood out as in need of fortification and bolstering, as it had kind of weathered much of the public health emergency to finally receive some benefit, enhanced payments here through the American Rescue Plan. So just for a refresh, it increases the FMAP for HCBS by 10%. It runs from April 1st of this year through March 31st of 24. And it was designed to accomplish two major objectives. One, to really stabilize the HCBS system, as I'd mentioned, and two, provide COVID relief to the direct care workforce and begin to address some of the structural issues that result in chronic workforce shortages. Along with the American Rescue Plan and this enhanced match, there were some requirements that went along. Noteworthy there would be a maintenance of effort requirement on HCBS, so that states would need to make sure that people continue to receive their services. And a quick readout of the activity around this, it appears that most states are preparing and submitting plans to CMS to draw down this money. In fact, as of July of this year, 34 of the states had made their plans publicly available and posted them to websites, et cetera. So it does look like there's really decent and significant uptake here. We haven't yet heard from CMS about the spending plan approval, but we expect that to be forthcoming. So quickly, some examples of the type of funding. I mentioned the workforce, and obviously to strengthen that workforce, there was a real interest in rewarding those direct care providers that had weathered the COVID storm or were actually still experiencing it in February when the bill passed. So there are enhanced payments to that workforce, often accomplished by putting forward a pass-through to get those wages to go from the provider directly to the direct care workforce. There were efforts in some states to standardize curriculum and training for the personal care workforce. And noteworthy is an interest in expanding the data infrastructure to better understand workforce supply and demand. Again, these things are all going to be critical for us to really stabilize the workforce and have an ongoing HCBS system that can marry up with the rest of the delivery system. Of course, states have money to enhance services in this. Since it is time limited, states don't appear to be adding additional large numbers of people to the rolls. There are certainly examples of states where they are bringing people, say, off of a waiting list and beginning to serve them with this time-limited money. But a general statement would be that they're looking at temporary investments in the types of services that they're experiencing real challenges in. An example of that would be our behavioral health system. A number of states were making critical investments there. Other areas that were noteworthy, there is a heightened focus on equity issues. and looking at how we can address issues related to populations like the Black, Indigenous people of color groups, so that we can ensure hopefully greater health equity by making investments in HCBS. There were examples in states with large tribal populations making grants to these tribes. So it'll be interesting to see how CMS views that. Now I'm just going to quickly switch over to what is happening in the reconciliation package. It is designed largely after a legislation that came out of Senate Aging and a couple of other senators' offices. It was called the Better Jobs or Better Care, Better Jobs Act. And it has some interesting features, but it's really designed in many ways to be a bridge to for this temporary funding, so that ideally we would have seen a 10% enhanced FMAP in the Better Jobs, Better Care Act. So what does this really do? It would put that 10% enhanced FMAP in perpetuity, so that states would be able to begin to expand enrollment. In other words, taking people off waiting lists is one of the key objectives that the advocacy community often falls back on. Finding and addressing the key structural issues that result in these chronic workforce shortages. This will need to be coupled with a host of administrative actions, hopefully that CMS is gearing up to take on. But indeed, this legislation is designed in some ways to begin to address what is often referred to as an institutional bias in Medicaid. And finally, I can just quickly report out on we have Energy and Commerce marking up this reconciliation package, and they went into the program and attached basically $190 billion to the program, which is a very significant investment in the program. It's not the $400 billion that was called for by the administration or contemplated in the Better Care, Better Jobs Act, but the advocacy community I know is active in trying to get that number up. Yet alone, $190 billion is a sizable number to be talking about. What does that include? There are, as drafted, $130 million in HCBS improvement planning grants to states. So this would basically get the work going at the state level. As the legislation passed, it included a 7% enhanced FMAP. So you can see it accommodating the change from 400 billion to 190 billion. There's also, interestingly, a second enhanced FMAP in here, and that would be an additional 2% enhanced FMAP for 2 years for states to work on self-directed programs. And another feature is an enhanced administrative match for HCBS related activities, and that's at 80%. Just to note, this legislation would also make permanent spousal impoverishment protections, and the money follows the person program. I think with that, I need to hand it off to Haley. Thanks.
Thanks, Henry. Well, I'm so pleased to be here with all of you today and really just tackling this really important topic. So kudos to the Bipartisan Policy Center for continuing to do such good work in this area. I'm Hamie Tawarson. I'm the Executive Director here at the National Academy for State Health Policy. And for those of you who don't know NASHP, we are a nonpartisan forum of policymakers throughout state government, different levels of the executive branch as well as the legislative branch, and really working in a bipartisan way across all the different topics. I'm really happy to be here today because we have been investing a fair amount of our resources in working on sort of aging and disabled populations. And one of the things we have done is really take a look at, and Henry already did some explanation of this, so I will try to just add on and supplement, what states are really planning to do with the money that they've gotten from ARPA. And where else do they really feel like they need investments? Just taking a step back, when you look at sort of gubernatorial priorities, you don't often see aging listed. There have been some governors that have decided to take this in hand and be a leader in this area, but not all. And what's been interesting about this pandemic is it really has shone a bright light on some of the vulnerabilities in our system and how we care for the aging and the disabled populations within sort of long-term care facilities and sort of a limited workforce when people want to stay in the home. And so with the population expanding, as we all know that it's going to be, it really is important to make these sort of longer term investments. And from where I sit, I think ARPA is a really good start with that. It's giving states money now in the context of a pandemic when we've seen that there's an opportunity and need to change. And I think states are being somewhat creative with how to use that funding. I'll just say from my perspective, there's limitations to that because the funding, the bump in the FMAP that Henry so eloquently explained is only for 1 year. And so, from a state budgetary perspective, states make different decisions when they have time limited money. With a 1 year bump like that, some states are deciding, we really need to make sure whatever investments we make, we're not going to be obligated to continue to carry those expenses after we lose that bump. While others are saying, we're going to make the investments now, we need to, and we're going to just have to figure out how we're going to finance it on an ongoing basis as we move forward. So just to provide a little bit more flavor to what Henry talked about in terms of like how are states actually thinking about these ARPA monies? They're all outlined in their plan. As Henry explained, it's not been approved yet by CMS, but they have generally followed the guidance. So I guess we don't expect there'll be huge significant changes, but we'll see. So a lot of states are thinking about how do we increase overall service capacity. I think with the pandemic, we've seen there's more folks that want to be at home, and there's more folks that need services at home, and there's waiting lists for these waiver services. And so some states have decided we're gonna really take a look at our waiver slots. We're going to really reduce it. New Mexico, for example, is proposing to add 1,000 age and disabled waiver slots and 400 developmental disability waiver slots. Tennessee is proposing to serve 2,000 people who are on the Employment and Community First Choices waiver waiting list. So really trying in the short term to say, hey, these folks have been waiting for services, let's get to them. I think there's a handful of states, as I mentioned, that are taking the leap to propose implementation of permanent rate increases for some sectors of the HCBS workforce. Long-term care, most commonly, but also in mental health. We do have an emerging sort of mental health, I won't use the word crisis, but really significant needs coming out of this pandemic that were already there before, but now are even more so with people in isolation. So those states are saying, look, we're going to increase it. We're going to have to absorb this into state budgets if and when this 10% doesn't continue on after the year. But other states are taking a slightly different approach, not wanting to take on that responsibility and liability. And they're looking at like, how do we do a specialty pay approach? And we can have sign-on bonuses when we hire folks so we can get them into the workforce, or we can have hero or overtime pay to make sure that those are in the workforce will stay there. So I think, it just kind of depends on the state perspective and where they want to spend the money. Workforce, I can't say enough about workforce. I mean, that was addressed in this report. It is such a need, and it has been for quite a long time. And we really need to figure out how to make change. And the time is now. There's a number of states that are really trying to invest in training. Wisconsin, for example, is interested in developing professional career ladders for personal care and supportive home workers. Illinois is proposing funding dedicated to provider trainings for Hep C. Washington is proposing to fund peer mentors at all 4 state residential habilitative centers to help navigate transitions back to community living. And there's more, just trying to give you a flavor. I think there are other states that also want to have a better analytics around where are the gaps. And so Georgia has included a HCBS workforce assessment to review, how they're retaining and recruiting and developing the workforce that they're going to need over the next many years. I will say the other piece where states are proposing is transitions to care. So, I think a number of states see that there have been gaps, and it was exacerbated by this pandemic of moving folks from places like skilled nursing facilities to longer term care facilities. So that is transition planning is a theme in a number of the proposals that state spend. Washington State is proposing supports for transitions from SNFs into homes in the community by providing rental subsidies, as well as incentive payments to providers who accept individuals being discharged from acute care hospitals. So really trying to get them to, either their home or a safe place where they can stay longer term. In order to help with the initial cost of transitioning from nursing facilities, Wyoming is proposing a fund to cover costs like first and last month rent, security deposits, pantry items, and basic furnishings. So, and an interesting one in Colorado is there's a program that would pair older adults with college students who need affordable housing. So Colorado trying to be a bit creative in thinking about how to address housing. I also want to just talk a bit about behavioral health. So Henry talked about this, but really the supports for behavioral health is another common theme, and really we need to make more investments. Just one example, mobile crisis is something that has risen to the top in many states. Just as one example, West Virginia specifically mentions they're going to expand their existing mobile crisis sites to be able to provide services for individuals with intellectual disabilities, because they have seen an increased need in that, and it's really hard to reach those populations. So mobile is the way to do that. I will also say just, a lot of states have talked about equity, and Henry already really explained that. But on the technology side, we also need to make investments to really improve tech capacity in HCBS systems. And a number of the states are proposing things like extending admissions, discharge, and transfer notifications to HCPS providers, and providing grants to providers and our families for assistive technology and broadband. Colorado is planning to connect and share data across state agencies and providers to better understand and track HCBS populations. And another example is Massachusetts is proposing the development of a public LTSS dashboard that would link facility and community-based services and demographic data. So, and I'm just going to take just 2 more minutes because I know we want to get to the discussion part and we want to get to Caroline. I just did also want to mention on family caregiving, that also was a topic that came up in these plans. And family caregivers provide an estimated $470 billion per year in uncompensated care. And really, if we're going to keep more folks in the home, we have to figure out how to support some of these caregivers in a better way. And I think states, particularly in the wake of COVID, are really increasingly interested in thinking about how do we tailor services and supports for family caregivers and expand payments to Medicaid waivers and the like. And so we saw when we looked at the ARPA plans, a number of states, including family caregiver supports, and that included support for Medicaid payments, training, and counseling to make sure that caregivers have what they need. I would also say that there's a number of states that really have been thinking about where do we go next with family caregiving, and we can get into this, Marilyn, in the discussion about some ideas around what's happening at the federal level versus what's happening at the state level. And for some states, really just identifying where are the gaps. And I think that's part of the challenge, I think, that some states who haven't really looked into this are facing. So I will now turn it over to Caroline, who's going to talk about the middle. So
thanks, Amy. Well, thank you for having me. I'm thrilled to be on the panel, and congrats on the release of this very important work. I want to talk today about some work that we published in Health Affairs in 2019, which really sought to describe the size, demographics, health status, and financial needs of people who will be over age 75 in 2029, so future seniors. And I'm going to talk both about the population as a whole, but then importantly on the group that we really wanted to highlight, which is the forgotten middle, people who are unlikely to qualify for Medicaid heading into their older years, and are unlikely to be able to afford many of the private seniors housing options, whether that be assisted living or nursing care, that they may need as their health, mobility, and cognitive status may decline. But before I do that, let me tell you a bit about what the changes are going to be in America's aging population, because I think it really underscores the importance of this report and really this country taking seriously the unmet long-term care needs of all seniors. We looked at data beginning with sort of a baseline in 2014 and then again projecting out to 2029. And we all know that the baby boomers is a big population and it's going to result in a lot of growth. But to give you a sense of numbers, we're going to see an increase in, by 68% in the size of the population age 75 and older from 20 million in 2014 to almost 34 million in 2029. And that's really just the start of the wave. In 2029, the oldest baby boomer will be 83. So we won't have even begun to hit that cohort being 85 and older and really beginning to see increase in the level of care needs that they're going to have. Now, demographically, the population is going to grow more diverse. So we're going to see about 16% of that group being racial and ethnic minorities. And so I think we should think about the impact that that is going to have on care needs and access to care. So I was thrilled to see diversity as a key element in this report. But as we think about the care structures that folks rely on today, particularly before they begin to need paid or outside the home care, we do see demographic changes in this generation of older adults. So these seniors are much less likely to be married than today's seniors. We see marriage rates down to about 52% from 62% in 2014. And as we all know, spouses are sort of the first line of caregiving and keeping folks safe in their home. We also see that this generation had fewer children, and those children are less likely to live nearby. So while recent analysis has shown no recent changes in the sort of amount of unpaid caregiving that seniors are receiving, we do need to wonder heading into the future whether those unpaid familial caregivers that we depend on so heavily today to keep our lack of system afloat are going to be available to seniors over the next 10 and 20 years. The third aspect of our analysis was really looking at financial resources, right? This is the rubber that meets the road in terms of what kinds of housing and in-home support folks can afford and what sorts of public coverage may be available to them. We included all aspects of wealth, so income like Social Security and pensions, assets including retirement savings, and then we conducted all of our analysis with and without housing equity, understanding that sort of the family home is a sensitive subject and one that may be able to be part of resources for some people and not for others. We also adjusted for the finances of couples and how those finances change as one spouse may pass in future years. What we see, first, some really good news is we actually see very little growth over the next 10 years in the size of the lowest income likely to be Medicaid eligible population. And this is really driven by the improvements that we've seen in education from a generation where high school attendance was not necessarily required to seniors in 2029 for whom only 3% do not have a high school degree. We also see big increases in the rates of college education in this cohort. And again, that's really driving an increase in the financial resources that they're going to have available to them, which is wonderful news. But now that important forgotten middle. So we looked again at a group who is unlikely to qualify for Medicaid without having spend down, having their health decline and needing to spend down, which is certainly a possibility in the future. And that middle income cohort of seniors is projected to grow 82% over the next decade. And that's going to be about 43% of our entire senior population. And again, this is 43% of older adults for whom the existing policy solutions, subsidies, and market-based private solutions really do not serve them today. These are folks who largely depend on unpaid family caregiving and other options. Now, not all of them are going to need additional support, but we did look at health status and we project that about 20% of that middle income group will be high needs, meaning they have 3 or more chronic health conditions and limitations in their activities of daily living. 6% of them have mobility and cognitive impairment at the age of 75, and we know that that's going to increase dramatically with age. And so, this is really going to be a growing and important problem. And as we begin to talk about solutions, I was thrilled to see that the report includes solutions that might reach up and address some of the folks in this middle income cohort. And as we get into the discussion, I look forward to talking more about what the options might be for that population. But at this point, I'll pass it back to Marilyn.
Excellent. Thank you very much to all of our speakers for laying the foundation for this discussion. Just a reminder, we're already receiving some questions, but if you have questions, and you can submit your questions using the live chat on YouTube or Facebook, or you can also always submit a question via Twitter using the hashtag BPCLive. Caroline, let me just build on what you were just saying. You were talking about the forgotten middle. And why aren't middle income Americans doing more to prepare for their long-term services and supports and needs? And we've already had one question related to this. The report mentions a public education campaign for long-term care. If campaigns haven't been successful in the past, how do we spread the word about long-term care now and get people to realize that they will likely have a long-term care need during their lifetime? So what is it about this preparation? Why don't we have people preparing?
Well, I don't know that I have the perfect answer. I think you raised really important issues in the report. Many people do not understand what coverage options are going to be available to them. The long-term care insurance industry has been a challenging market, very expensive and sort of declining in terms of its presence. And I think there's an element, which is the honest answer, that is lots of folks don't want to think very carefully about a state in which their health is going to decline and they may not be able to live independently. We do surveys, a lot of surveys at NORC. And when you survey people and you say, where do you want to live when you get older? Everyone says we want to stay in our home. But when you start to ask more nuanced questions about where do you want to live if you had mobility limitations, or if you had cognitive limitations, or as many folks who care for individuals with dementia can tell you, if your family caregiver simply can't provide the level of safety and care that you need, then things start to change. But that's not a reality many of us want to contend with, and unfortunately, it's not one that I think we as a society have done a good job of flagging.
Yes, Amy.
Yeah, I just wanted to chime in. I totally agree with Caroline. And I think, there is a time when people start thinking about their needs and they do want to buy insurance, but then it's prohibitively expensive because there isn't a stable market. And so that's the challenge. And I just wanted to mention we've been talking to a couple of states about this, and they're frustrated because, they have the power to regulate insurance markets, but it's just tough because there isn't the competition and there's not the stability there. I just wanted to mention Washington State, because they're the first state in the nation. They're trying to take it on themselves for their state employees. And they're creating the Washington Care Fund, where state employees are going to pay in when they're a lot younger, and it's just part of the process at a low amount, so that they have a benefit when they get older. Right now, it's limited; it's like around $36,000, which we all know if you really need long-term care, that won't pay for many years of that. But I think it's just a really tricky question of how do we really get back to providing some stable, affordable options for people, which really doesn't exist. And I think if they did exist, you'd see more people buying them. I really do. So.
Anybody else? Lena, did you want to jump in?
Yeah, I agree both with Carolyn and Hemi. One of the things I want to point out is we recently did focus groups with low-income older adults in the context of, integrating health with housing. But it was very similar. It's hard for individuals to imagine looking maybe 10, 15 years down the road as to what their care needs will be. You don't want to think about, I'm going to need, personal care services for several hours a week, or I may have a health crisis. And so our individuals have a hard time. But one of the things that I wanted to point out is it's important to elevate the stories of people who are receiving home and community-based services, whether the stories of how their experiences are, and elevating that to create the narrative of why these services are so critical, why it helps to keep them at home, and the importance of expanding these services so that more people can receive them.
And Marilyn, I'd just quickly add, one minor contributing factor might be that some people are under the misperception that Medicare covers long-term care. And, really until recently, Medicare referred to it as a long-term care benefit. So the mixed messaging that comes out, I think, doesn't help us.
So I heard a number of you talk about the problems of workforce. In fact, we heard some staggering numbers here today. Hammy, you talked about states stepping forward, and we know that increasingly states are stepping forward to address the needs of those who don't qualify for Medicaid. But can you expand on the work states are doing to support family caregivers? And here again, we're talking about we have such a shortage in the workforce, and a big part of our workforce is family. Well, it's not the workforce; it's our family caregivers. So tell us about what states are doing there.
Yeah, thanks for that question. So there are a number of states that are just starting to get their arms around, how to really effectively support family caregiving, while other states have been doing this for a while. So I'll just maybe talk about the range of where they are. And Washington State is one that's is ahead, I would say, of the curve on this. And so they identify family caregivers of individuals who are either not eligible for Medicaid waiver services or are eligible but aren't actually using the HCBS piece first. Or yet. And so they are basically trying to go upstream to say, okay, these people, they're gonna need it soon, but we know they have family caregivers that are keeping them in the home and keeping them before they sort of go around the corner and have to get more intensive services. Let's try to stabilize that for a longer period of time. And the Medicaid program is actually paying caregiver supports to those folks to make sure that they're able to continue to do what they're doing, because people have to not go to work, and they have to spend their own finances to try to support the person in the home. And so there's a lot that goes into that. California is another state that has some really interesting and innovative caregiver resource centers, which I think as part of sort of the California Master Plan on Aging, this piece I think is integral into trying to keep people where they are and keep people in a place where they're going to thrive. There's other states that we've been working with, such as Illinois, New York, and Utah, which are, they're really trying to understand, how do we get caregiver assessment? So we really understand what the needs are. So it's not just a Medicaid benefit, but actually figuring out, what are the types of services that are going to keep caregivers going, and how do we help support them and make sure we understand who they are and what they need. And then another interesting example I would just share would be Connecticut. We're also working with Connecticut in our Policy Academy, and they're working out new contracts with the DSNPs and their AAAs and Department of Labor to better align services and supports across these systems. And so they're trying to explore how Medicaid payment to family caregivers and the state's new paid family leave law might intersect and provide some meaningful financial supports to families, and how they can leverage the DSNP contracts to better align the AAA Medicaid resources. So, and one last thing I'll just say is, there is the sort of Congress passing the Recognize, Assist, Include, Support, and Engage, the RAISE Family Caregivers Act in 2018. And that right now is, rolling out, and NASHB has been involved, and we've set up a council to try to figure out how can states really benefit from this, where can they go next? And so for those of you that are interested, we're going to release in partnership with the RAISE Council, a policy roadmap for family caregivers based on 26 of the recommendations. So that's coming out soon too.
Okay. We have also had a question that keeps us on workforce for right now, and that is about the extreme workforce shortages for home health aides. These are low-paying jobs. They can be entry-level jobs. How do we recruit and retain more home health aides? This is for anybody who wants to jump in.
It's Henry. I'd be happy to jump in. I think many states see this as a critical need to raise the basic wage of the direct care worker. And I think there are a number of issues that contribute to that. But I think we have to look historically at the low rates that are paid to providers and how that factors into direct care workforce. So again, hopefully there will be administrative action that takes place and accompanies this to really fortify a system that better understands what the workers' wages are and how they relate to the quality of care that's delivered. and begin to reward that work in ways that ultimately result in better compensation. Because without addressing that factor, these jobs are going to be difficult to fill, and the quality of the care is going to continue to suffer.
Yes, Amy.
I totally agree. And I would just add, I think some states are trying to, and this is true in other areas of workforce as well. There's a shortage in a lot of different areas, is like, how do you build the curriculum and the momentum around to recruit folks to be interested in taking these jobs? And you have to start sort of earlier in the pipeline, and you have to make it something that's appealing to younger folks coming out of school, and like, what are programs to consider? And so I think states are exploring all those pieces, and I think we all need to, because the amount of folks that are right now interested, to Henry's point, just based on salary alone, is quite limited. And we really need to build a better pipeline into that workforce to make sure we have enough workers for what we know is coming.
What about the special needs in rural areas? This is for any specialty area in healthcare or healthcare support. This is a difficult place to be looking for, to provide comprehensive support. So what are the special needs in rural areas, and what are some of the special challenges in rural areas? And are there any interesting state approaches or any approaches in general in addressing them?
I can jump in, Marilyn, with I'm a former Colorado resident, so I did look at their spending plan with great interest and found that they addressed this in their kind of innovation section. And they are really looking at trying to create some smaller settings in rural areas where they can serve people, not in large congregate settings, but in smaller group settings in rural areas. So I think the details were just, at the idea stage, but I think it's essential that we address this, because right now, I think most people leave rural or frontier areas for urban areas to seek services, simply because they're not able to find a provider or another person to come in and provide the care that they need. So we do need a lot of help in this area.
Amy, have you seen anything in particular from the states that get right to the rural issues?
Yeah, some of them are looking at sort of mobile services and thinking about how to provide more mobile services. They can reach more areas more easily. It's also investing in the family caregiving when you're not going to have the workers. I mean, I think that's just the reality for, it's true of behavioral health too. Like, you just know we're just not going to have enough workers for every part of it, especially like in a frontier state. So, how do we support the caregivers? How do we provide, supports on sort of the social services side, housing or whatnot, to allow people to stay in the home for longer periods of time, and then have a mobile element to that. The recruiting and training, I think, is harder for some rural areas. So that's going to continue to be a challenge.
Okay, so we have a question that gets the timeliest issue, what we're dealing with right now, the $190 billion to expand home and community-based services and reconciliation. And the questioner wants to know, if this is not even half of what President Biden has proposed, what would a substantial long-term solution to expand home and community-based services look like?
I'll jump in again. It's Henry. I think there is an opportunity here that this is really a long-term problem. There is an institutional bias in Medicaid, and this investment is really would be important in beginning to address that. This is a systemic issue, and it won't go away easily. I think there are other areas of investment. The BPC does interesting work on integrated care that was highlighted here in the report. And thinking about the role that HCBS plays in stabilizing health outcomes, hopefully there will be a realization about the value of investing strategically in these services. And it will be a combination of investing additional resources and right-sizing our delivery system to deliver more care in the community.
Henry, let's take a half a step back from that. Given what's going on in Congress, what are the consumers' expectations, and how do those expectations align with the reality of what's going on in Congress on this issue?
Yeah, it's kind of a historic moment, I think, in terms of the consumers that rely on this program, at least in their advocacy networks. They really sense that this is the time when a significant investment could be made in the program. And they've been very active in keeping Congress informed about the importance of this investment. And I do think, to go to an earlier question, one of the challenges is people really have a difficult time confronting what life would be like if you didn't have the functional ability that you live with each day. And therefore, it's left to groups that are living with these issues to really raise the kind of the level of the volume around the need. But honestly, I think what would really help is if we had better reporting on these issues by the media. If you'll look at all of the reporting on the reconciliation package, you often see people struggle to talk about the HCBS investment and have a one-off description of it as elder care. And that really frustrates the advocacy community because they're so in touch with what these needs are. And, there are families waiting for services today. There are people in the Medicaid program with unmet needs because states don't have the dollars to invest in them. And so this enhanced investment is an initial down payment on addressing this long-term institutional bias that exists in Medicaid.
So, go ahead.
No, I was just going to say, I absolutely agree. And I think it just goes back to earlier around just the narrative around home and community-based services and the need in elevating those stories. I don't think we hear enough in mainstream media about what this actually means for families and for the people receiving these services and how that actually impacts the quality of their life. And I think, the investments, the conversations that are happening now, the investments that will be potentially made into home and community service, they are historic. There is the potential to advance, health justice and racial justice. It's the original conversation of 400 billion. I mean, that's what's needed. I think someone said earlier, I think maybe it was Hemi, like, it's unpaid caregiving, $476 billion. And we're talking about, this level of investment. So I think the conversations amongst advocates is really about making, yes, it's history, but, the more investments are needed. And I think the narrative really needs to shift from what this means to people who rely on these services.
Yeah. So when we're looking, Caroline, were you just about to weigh in?
Yeah, I was just going to say briefly. I mean, I think politics being what it is hard to not always sort of want to succeed with a big package. I liked Henry's framing on sort of a down payment on the future. I do think that we have tried before and failed to do sort of major, audacious long-term care reforms. And I hope that we see something really significant right now. But we need to think about this as the beginning of an incremental process. I mean, I was stunned when we released our report 2 years ago. There was just this silence. We would present and folks would sort of sit in dumbfounded silence with the weight, the sort of magnitude of the problem in front of us. And, I think that's paralyzed us for a long time. And so I think this is a huge step forward. I would also argue we need to start to pull the private sector into this discussion because it doesn't have to be a purely public sector solution. And actually there are private resources available if we got a little more creative and organized about how we helped people find those and how we deliver them to people. So that's my last point.
In looking at how we move forward on this, I think it would be very helpful for our viewers to have a better understanding of what the competing priorities are that members of Congress are facing.
Well, I would just call one out, and I think the caring economy is a wonderful frame for how we're going and entering into this. But when you look at where the advocacy groups land, you'll see women's groups aligning much more with the child care proposal and not as much with the investment in our long-term care system. And so I think there is some work that needs to be done there in coalition building across these, because let's remember that the coalitions that have gotten the bill this far have largely been developmental disabilities providers and organizations that represent workforce, even labor unions, to really make this number stick. So there's a lot of work to do still building coalitions.
And yes, Amy?
Yeah, and I just say, the debate, particularly in the Senate on, how much should this bill really cost? I mean, there's a lot of interest in expanding Medicare, right, to provide dental, vision, and hearing benefits, which will be appreciated by millions across the country. There's an interest in expanding Medicaid in those states that haven't yet expanded to provide access to people who don't have any access to insurance right now. There's an interest in expanding the subsidies that are provided right now through the exchanges so that there's more affordability for those that are getting access through the marketplaces. So, as in reconciliation in the past, there's a lot of different worthy priorities. And I think, when you have pressure on how much the bill can be in terms of totality of spend, you're going to get this debate. I think the other piece to think about is, how do we balance the cost with the savings? And, some of this is on prescription drug reform that they're actually going to be able to balance the cost. And, I think some folks in the House versus the Senate may want to be more or less aggressive on where we get those savings. So as in any time in Congress, this is a negotiation. I hope that there's a lot of good that can come out of the bill and a lot of good support for those that need it, including those in the HCBS community.
Assuming that legislation does pass to further expand home and community-based services, what needs to happen to ensure successful implementation? Henry, you have experience at both the Centers for Medicare and Medicaid Services and at the Administration for Community Living. What can be done at the agency level to encourage expansion?
That's a great question. I think that CMS is a large agency and the Medicaid program touches a lot of people's lives. Historically, HCBS, and let's remember, remains largely optional. So this is the province of the states. CMS hasn't had a major leading role here. And so I think the agency has really struggled with what can it do best to incent state action. And I do think that the new leadership is up to the challenge and they're working on ways to identify really innovative key state actions that will allow for expansion of HCBS. And I think that's the type of work that can be done to support states, really promoting this kind of learning collaborative so that states pick up on best practices and replicate them. But honestly, with optional services, I think we're going to be looking at states and supporting them to expand and provide these services.
Okay, Hammy, we have a question that follows up on what you were talking about. And our audience member wants to know, what about non-Medicaid home and community-based services? The person's concern is with only relying on expanding Medicaid home and community-based services. In many cases, a person is forced into poverty before they can qualify for care. So how do we keep from getting to that point?
We need a better insurance system. Right now, Medicaid is the primary payer for home and community-based services along with nursing care. We've as a country have structured our policies to make that so. And so, there really needs to be, Washington's being somewhat innovative and trying to catch folks before they spend down, and using Medicaid to pay those folks. That's one sort of small example. But in terms of like big reform, I think we need more stability in the insurance market to give folks other options besides Medicaid to help cover those services. Because, unless you have really good long-term care insurance, you're not going to be able, or can pay out of pocket yourself, you're not going to be able to pay for those without spending down.
Mhm.
I don't know if others have other thoughts on this, though.
Yeah, I mean, I think there's a lot of opportunity to sort of leverage existing resources and keep people in their homes longer, right? So when you begin to look at the cost of care as people age, housing is a huge component. If we can safely and effectively keep people in their homes, that really lowers our annual cost of care. But I think we've got a long way to go in terms of organizing HCBS services, even private pay ones, into sort of centralized modules that are easier to access, right? In a year, I live in an urban environment, in a year in which I've basically had everything delivered to my house and all services come to me. I think it's a good time for innovation, right? We know that we have sort of new, IT-based, gig economy-based solutions to get people a lot of the kinds of services they need. Not all of them. We certainly need caregivers to go into the homes as well. But it is very piecemeal. And so I think there is some innovation that we could do around how do we create sort of packages of, of access points to services where you can tap into those that you need, have some quality sense that you're getting something that is going to be effective and safe. And so I do think we should continue to focus there because the Medicaid paid services have sort of crowded out attention, I think, relative to the private market.
Okay. Lena, can you talk about the work that Community Catalyst is doing in terms of its consumer engagement activities? What are the organization's priorities in advancing person-centered long-term care?
I was actually just going to touch on that. I think, going back to earlier conversation about, CMS, big agency, complicated, sort of working together, how that trickles down to the state level. I think from our perspective, it is critical to engage the different community voices. I think when you have buy-in from the ground up, you have a successful program. One of our priorities right now in this current conversation is make Medicaid home and community-based services mandatory. And a lot goes along with that and fits in with some of our priorities like data collection and making sure that data collection is, intersectional so that when we're looking at the utilization of data, we are able to then make improvements into the services that are offered. The workforce piece that we've all touched on today is critical, and making sure that the direct care workforce is compensated appropriately, that they are trained and they have the supports that they need in order to serve the population, and then to ensure that services are delivered to individuals in a manner that is culturally competent, that takes into consideration their own personal and life goals, and to that of those of their caregivers. I think those would be some of the top line that we think about, and sort of weaving through each of that, as I had said earlier in my statements, is thinking about the disproportionate population that this is, the communities of color, and how I think one of the statistics was that 16% of this growing population will be from, minority populations. And so how do we address, make policies, make practices that are going to address care for those needs? And you have to think about that from a very cultural perspective, a linguistic perspective, down to the level of the type of, nutrition that individuals receive. I mean, I have personal experience with that, with my grandmother having dementia and, needing very culturally competent care. And so those, those are some of the things that we think about when we think about long-term care.
And there's another population we really need to address before we start to wrap up. Henry, can you talk a bit about the needs of working individuals with disabilities and what kinds of state options are available to allow these folks to buy into Medicaid for LTSS? We know that there's a pretty big need here. Henry?
Sure, there are some structural challenges we face, and largely disability has been, in many cases, and currently is by the Social Security Administration, defined as an inability to perform what's called substantial gainful activity. So, the making the disability experience synonymous with an inability to earn is a real challenge. We know that there are many people with significant disabilities that need things like home and community-based services that are uniquely available through the Medicaid program to work. And yet, once they have significant earnings, they're no longer eligible for Medicaid. So we've had these eligibility pathways created for the Medicaid buy-in program for working disabled people. But largely, they're undersubscribed. In most states, they limit income up to 250% of poverty. So these really haven't been programs that states have invested significantly in terms of lifting the income levels. And what's important to remember is that there are asset limits attached. And so any worker that is going to be earning is going to hopefully accumulate savings and for retirement, et cetera. So if you're unable to hold on to those, then it really frustrates the individual's ability to work. So you often see a cohort of people that are successful at leaving Medicaid entirely behind to go to work. But I do think there is a real need for these programs to be revitalized and, frankly, to get into the eligibility rules and adjust them to make them easier for states to take advantage of, provide better technical assistance to states on the real budgetary impacts of structuring these buy-in programs so they're very targeted to these individuals that I identified earlier. And then we can give it a proper test to see, what we might get in terms of really having people with significant disabilities that rely on HCBS to go to work to actually take jobs and come home with real earnings.
Thank you, Henry. I'm going to use my prerogative to make the last question the magic wand question. If you could wave, each of you, if you could wave your magic wand and instantly make one policy change to help expand or improve long-term care, what would you do? What is at the top of your priority list that you feel would make a big difference? Caroline?
So I'm going to borrow from my friends Ann Tomlinson and David Grabowski, who recently published this suggestion, which is, the funding, the program coverage, it's really important, but this is a confusing landscape. This has been an alphabet soup webinar, and for regular folks who are trying to help themselves or their loved ones as they, potentially are discharged from a hospital and have changing care needs, it is very difficult to know where to begin. And so I would say, regardless of how much funding we have for public programs, funding a navigation service, a place to begin to connect you to both the public and the private resources that are available to you would be a huge step in the right direction.
Hammy?
I would say that, Medicaid shouldn't be the only option for folks that need long-term care, whether it's in the home or whether it's in a nursing facility. And so really building a more stable market where folks can understand what the options are and have affordable choices earlier in their lives would be, I think, a huge lift to those who will need services later in life.
Thank you, Lena.
You just get to pick one. But if I could wave a magic wand, certainly I think in this current environment, it would be great to see mandatory Medicaid home and community-based service go through. I think that would be sensational.
Okay, Henry?
And I, support all of my colleagues' proposals and wave my wand a bunch of times. But just to reinforce Caroline's point, we really do need leadership here in terms of and sustained engagement and not just one-off ventures into addressing long-term care or home and community-based services. We need to think about this as a system, as part of the healthcare delivery system. And it's not discussed that way. I would argue that, it doesn't get covered in health affairs that way either. We need to be thinking about how to bring this part of our delivery system up to par so that it can really take the burden off of hospitals when people are being discharged, so that they don't have to go directly to a nursing home. They could actually go home with the right type of support. So if I could wave my wand, I would make sure that every person on hospital discharge had the option to return home.
Excellent. Thank you so much. So we have run out of time. Many thanks again to the Robert Wood Johnson Foundation and SCAN for their generous support. Many thanks to all of our panelists and those who participated and helped us today. I want to just mention, if you would like to see our report and you don't have it, you can find it very easily on our website, bipartisanpolicy.org. Also, I want to mention that in related work, in October, we're going to be coming out with another report that's funded by Arnold Ventures on simplifying and streamlining Medicaid home and community-based services. And then following that in November, we will have a follow-up to our 2020 report on fully integrating care for dual eligible individuals. So please watch your inboxes for information about those. And again, thank you very much for attending and paying attention to this important topic.